Hello again. This is Earl Silverman, editor-in-chief of the Journal of Rheumatology, highlighting a paper of particular interest to the readership that will be published in December 2021. I guess I'm living in the past edition of the journal. The article I picked for my interview is entitled "The Clinical Disease Activity Index and the Routine Assessment of Patient Index Data 3 for Achievement of Treatment Strategies." It is by Kremer and colleagues on behalf of the Corona and Brass RA registries. The paper is now available for reading on the journal's website, as is an editorial regarding this paper entitled "Definition of Treatment Targets in Rheumatoid Arthritis. Is it Time for Reappraisal?" by Drs. Ferrara, Landaway, and De Silva from the University of Coimbra, Portugal, and the Zuiderland Medical Center and Amsterdam Medical Center, the Netherlands. I'm pleased to be speaking to Dr. Joel Kremer, about how the use of the CDAI or the RAPID3 may affect the treat-to-target decision in patients with rheumatoid arthritis. Joel, I want to thank you for taking the time to speak to me and our listeners. So we shall begin.
Well, thank you, Earl. My pleasure, my honor.
Thanks. So could you briefly describe the rationale for examining the CDAI, or the Clinical Disease Activity Index, and the RAPID3, or the Routine Assessment of Patient Index Data for achievement of treat-to-target strategies in RA?
Yes, that's a good question. We've always been interested in metrics and which metrics best capture legitimate patient outcomes. And I don't need to go over all the metrics that are available out there. There are certain ones that are used to get drugs approved by regulatory agencies. And then there are metrics that are hopefully more commonly used by clinicians as they care for patients. So they have a number with which they can assess disease activity and whether or not it might be appropriate to accelerate treatment in a treat-to-target regimen. So it was just one of many themes of this nature that was swimming around in my head at one point, and we decided to do the study.
Okay, good. Good swimming. So could you briefly outline the methodology used in the cohorts study?
Yes. We looked at the very last visit of 48,000 plus patients from the Corona, now RAPID3 registry. And we looked at their CDAIs. And the CDAI has a total of tender and swollen joints and physician and patient global. And it's a simple addition. It's easy to do in the clinic. And we looked at the same visit, collecting a metric called the RAPID3. And these are on the same patients on the same day, collected at the same time. And we did it in Corona, and to broaden the base, we also compared the results from the Brass registry. And the Brass registry is, of course, from the Brigham. And we collaborated with Nancy Shadick and Michael Weinblatt, Vivi, and others from that institution. And we determined whether or not the metrics from the CDAI versus the RAPID3 would place the patient in remission, low disease activity, moderate disease activity, or high disease activity. And then we went further and analyzed each component of each metric and determined to what extent that component, for instance, the patient global, the physician global, the tender and swollen joint counts, to what extent each of those metrics contributed to the final metric score within each of the metric systems. And we compared those systems for these outcomes with an interest in how much agreement or disagreement there might be between these metrics that might influence the decision to accelerate according to a treat to target goal.
Thank you. That was very good. But you answered what was going to be my next question, so we'll move on. So can you please outline then the major findings of the study?
Yeah, I had them grouped under 7 different findings. And so I'll read them off because it's too much to just make sure I do it well, to tell you the truth. So number 1, when the CDAI category is low disease activity, LDA, the RAPID3 agrees with LDA in 20.4% in corona and 28.5% in breast. So, I mean, not a very good agreement for LDA. When the CDAI is moderate disease activity, MDA, the RAPID3 agrees in 32.2% in corona and 40.5% in breast. When the RAPID3 would suggest treatment acceleration, that is, the patient is in moderate or high disease activity, 34.4% of these patients are in remission or low disease activity in corona, and 27.6% in breast. And the numbers are overwhelmingly much greater in corona. So we can say roughly a third of these patients that are in moderate or high disease activity, which would indicate they should be accelerated, are in remission or low disease activity with a CDAI in these 2 registries. The patient global, and I hope I have time to refer to this, there's some wonderful publications on really what the patient global represents. And I think they're included in the editorial. When we look at a Spearman correlation for the patient global, it's 0.91 and 0.94 in for the RAPID registry, whereas they're 0.71 and 0.58 for the CDAI. So essentially, when you look at a patient global in RAPID, that's really that's the core, that's the base of the RAPID. However, the MD global and the CDAI, the correlation is 0.78 for corona, 0.81 for breast, but dips down to 0.47 and 0.56 for breast. That's the MD global. So it's almost twice the correlation with the CDAI of the physician-derived global assessment of disease activity as it is in breast, which has no physician component to any of the evaluations. When we look at tender and swollen joints, which of course are a part of the CDAI, but are not contained in the RAPID registry, there is a CDAI correlation of 0.8 and 0.74 in a corona and RAPID, but that drops down to 0.48 and 0.31 with a RAPID3. So tender and swollen joints, the core of what rheumatologists do in evaluating a patient in the clinic at the time of an encounter in rheumatoid arthritis, the correlations are less than half with the CDAI when you're using the RAPID registry. And finally, and this is really interesting, there was a publication in A&R by Chua et al. In 2019. I can give you the full reference. And it indicated that the RAPID3, the same RAPID3 that we're using for RA, is a legitimate outcome measure in OA. So are our RA patients immune from having OA? Of course not. Of course, many of them indeed have OA, hip, knee, wherever. So if you're looking at a RAPID3, independent of the items I just enumerated, and you're looking at a patient global and patient pain, if indeed there is a publication documenting that that's a legitimate metric in OA, then what the heck are we measuring in these RA patients who also have OA? Are we measuring their OA, global and pain, or is it RA? Because we're using the same metric for both based upon this publication.
It's fascinating, and I know you didn't do it, but it would be very interesting to look at whether this varied then by disease duration, implying that, the longer your disease, the more likely you may have, or the older you are, more likely you may have OA. So a young person is, 5 years of disease on a biologic is unlikely to have much OA. It'll be a fascinating thing for the future.
Yeah, I think that's a great suggestion. We could look at age by decade and look at the contribution. But the other disparities, and we had table 4 of the manuscript, breaks down the individual components of each metric and the correlations with the total metric. And I tried to sum that up. But there are major differences. And some of the people we referenced, and there's 20 publications on the potential issues with the patient global, reflecting depression, anxiety, life satisfaction, even catastrophizing, that contribute, of course, to a patient global. And that's completely independent of how those same metrics would score in patients with simultaneous fibromyalgia. And we're actually looking at that in a different patient group in PSA, where we're using some fibromyalgia metrics. So the bottom line, what we wanted to describe is that there are different domains of patient welfare that are captured by the CDAI and by the RAPID. And they're both legitimate, but you're looking with the RAPID3 at non-inflammatory disease in RA. And I think, and I don't want to be the only one that claims to have established that, the publications that we quoted, and I gather are in the editorial which accompanies the publication, which I have not seen, I gather make the same point. It was interesting that there was a similar article in the October issue of the Rheumatologist by these same people who I gather have written the editorial. So we really, I think it's time to reevaluate how we use these metrics. And there are many, many good docs who are just trying to get through their day, understandably, who are using a patient-derived metric, patient global, patient pain, which we've shown on tens of thousands of measures across 2 registries, really correlate very poorly with inflammatory disease that would inform us about accelerating treatment and a treat to target philosophy.
That's excellent. And thank you for really explaining that. My next question is really, I think you addressed it also, is how does it compare to findings of studies outside of the US? I gather very similar.
Well, that was one of our concerns. Are our findings unique to US patients? I mean, the Corona Registry is on 42 sites, 700 plus physicians. We have a really large sample, and the Brass Registry is, of course, from the Brigham. So it's this US stuff. But in fact, we tried to make this point in the manuscript, that virtually all the studies questioning the what the patient global represents are derived from some really excellent studies, and they're virtually all European.
All right.
So humans are humans, whether they're European, African, Asian, whatever. So it appears from the peer-reviewed literature that what we found and analyzed in a fairly dense, data-driven manner is also relevant to other non-US, non-North American populations.
Yeah, not surprising, but it's nice to know. And my last question is, again, I think you addressed it. What are the implications for the routine outpatient care of patients with RA?
Well, I think the implications are that if we're treating a target, and if you have a patient in moderate or high disease activity, and you're relying on a RAPID3, that you could be misled, and that patient could be scoring that system based upon non-inflammatory but very human emotions. The psychology of that patient. Are they depressed? Are they anxious? What's their quality of life? Et cetera, et cetera. And these points are made extremely well by the quoted literature.
Yeah, I think what it tells me is that they give you potentially two different features of how to make your patients better in the holistic sense.
I absolutely agree. We shouldn't ignore the information from the RAPID. I think it tells you more about a 360-degree view of the human being in front of you, but don't adjust your treatment based upon that metric.
I think that's very important, and anything that you think we missed you'd like to add?
No, I can't think of anything. I can't think of anything else.
Well, that was an excellent overview, a very important paper, and I really want to thank Dr. Joel Kremer for taking the time to speak with me and for explaining how the use of the CDAI RAPID3 may affect a treat-to-target decision in patients with rheumatoid arthritis, as well as a holistic view of the patient. And to our viewers, please read the full article, Clinical Disease Activity Index and the Routine Assessment of the Patient Index 3 for Achievement of Treatment Strategies by Dr. Kremer and colleagues in the accompanying editorial. Definition of Treatment Targets in Rheumatoid Arthritis. Is it Time for Reappraisal by Drs. Ferraro, Landaway, and De Silva. Is available at jroom.org. And we'd love to hear your comments on Twitter at jroom or by email, manuscripts@jroom.com. And I want to thank you and hope you'll join us next month when I speak to the author of an article of particular interest that was selected for the January 2022 edition. And I want to wish you all a happy new year. And thank you, Joel.
Thank you very much, Ron.